to allow more people on. I'll introduce myself. My name is Susie Ferreira, and I am a member of PALCUS's Healthcare Committee. We're so excited that this is our very first health webinar with PALCUS, and we have a very well-known physician in women's health and fertility and reproductive technology and menopause. Dr. Lubna Pal, who will be speaking today, and I'll get more into her biography. Let me,
Thank you, Susie.
and this was brought to you by PALCUS. I'm going to share my screen. Hopefully you guys can see this. Thumbs up, Dr. Paul. Can you see that?
Yes. Yep.
Okay. Okay. Okay, so for those of you who are not familiar with PALCUS, we are the Portuguese American Leadership Council of the United States. It's a national nonprofit organization focused on strengthening the Portuguese American community through leadership, advocacy, education, and cultural connection. Our mission is to bring people together, amplify our community's voice, and create opportunities for engagement across the country. We're delighted to host this conversation and to have you join us today. Give me 1 second. Technical difficulties. Okay, now as you can see on the screen, we have Dr. Lubna Pal with us today. She is a professor of obstetrics and gynecology in the Department of Obstetrics, Gynecology, and Reproductive Sciences at Yale School of Medicine. She directs the program for menopause at Yale Reproductive Endocrinology. She's a recipient of multiple awards for clinical excellence, teaching, and for clinical research. She's published in numerous scientific journals, has edited multiple books on reproductive endocrinology and on menopause, and is recognized nationally and internationally for her commitment to reproductive wellness and patient well-being, on education of the next generation of clinicians and researchers, and for her work in the field of women's health. Dr. Paul, it's your turn to take it away. I will stop sharing.
Thank you so much, Susie. Thanks so much. What a pleasure being here. I only wish I could have had an opportunity to see the people at the other end, but what a privilege to be here. And I'm going to start so I have a slide deck that I will be sharing with all the attendees at the other end, but I'm hoping it's more of a conversation, and I'm hoping that people will feel comfortable posing questions about what are the dilemmas at your end? What would you want to know about this conversation? So with that, let me just and again, the slides, really, it's a launching of a conversation that we should all be a part of. And I am so privileged that in this month dedicated to women's health and women's wellness, your organization allowed me this opportunity to be the inaugural speaker for this concept of using this forum to optimize wellness and well-being of women in the community. The topic, so in this conversation will be the question, are we talking about menopause, or are we really talking about optimizing well-being and wellness as we course through life? And I'm hoping that in this conversation, I'm able to pitch to you that don't be afraid of this chapter ending, the chapter of reproductive function ending and a new chapter beginning. It's a continuum. It's a beautiful book of life. And we go from puberty into reproductive aging, into transition, into menopause, into postmenopause as a continuum. And really, the pitch that I want to make is aging is a privilege. It's not something to be afraid of. It's not something to consider a disease or a disorder. It's like puberty. It's a phase of life. And this phase, which in women, so men are biological males are aging at the same time as women are, but the orchestra is quiet in them. For women, this phase of transition and menopause sings loudly. something stops, right? Menstruation cessation happens, which is such a loud announcement that, hey, be prepared, another phase, another chapter is around the corner. So I think the conversation, I believe, should be around every phase of life. What can we do now that can optimize our next chapter? So that's really where knowledge and awareness brings empowerment. And the conversation about reproductive aging is the conversation about how can I optimize my next innings? These are my disclosures that are totally not relevant to the conversation that we're going to have today. But I bring to you the disclosure that I'm a believer that aging is a privilege, and these conversations are about how to shape the next for each one of us. So goals, I'm hoping in the 45 minutes, we'll touch upon having this understanding of what is normal part of aging and where the norms transgress into burden, where they can be a bother. And if there is a bother, we, the women, should be aware of what is the spectrum of bothers that could be associated with these changes in life, so that when you go meet with your healthcare provider, you are already forearmed with the knowledge, so you can ask the right questions. You can drive the conversation. You're empowered to be a part of the conversation. And the onus, the big picture is about thriving through this next phase of life. And in this context of thriving, recognizing that wherever I am today, my health in the future is dictated not just by where I am, but the journey that I have traversed thus far already. That includes my journey when I was in utero, when my mom was expecting me. What kind of pregnancy challenges did she experience when I was the fetus and the embryo? Then my birth happened, and my early pediatric years, what was the health then? What was my childhood going through? What was my reproductive years span that could have shaped my risk profile for as I age? For example, gynecological conditions such as polycystic ovary syndrome, menstrual irregularity, gynecological conditions such as uterine fibroids, endometriosis, PMS, premenstrual syndrome. These are common happenings in reproductive years, but each one of them may have some implications for the next chapter in my life, may shape my menopausal transition experience and my postmenopausal years. My family history becomes highly relevant. The genetics that has molded me, I can't change. I can change my lifestyle. I can improve so many aspects of my health. I can't undo the genetic template. But I, the person, if only I was aware of the genetic journey of my lineage, I may be more attentive to my personal risks. So if I come from a family where my dad had cardiovascular disease, heart disease, blood pressure problems in his 40s and 50s, that may have implications for my journey as I age. If my mom had diabetes in pregnancy, that may have implications for me. Stroke happening, depression, anxiety in my family members may be relevant to me. Then my reproductive history, if I was the person who in pregnancy developed preeclampsia, blood pressure problems, that may shape my future risk for cardiovascular disease, heart disease, risk of stroke. So all these stack up. And the pause moments really are to say, I want to understand my health journey, my health profile, so I can optimize what are the things I need to modify. Remember, biology is aging at the same time as we are stepping into these different stages of reproductive aging. And so much of our understanding is muddled by what we think is just menopause, whereas the underlying elements are biological aging. Right? So blood pressure changes, blood vessels are changing, they're becoming a little bit stiffer. Bone is changing, it is becoming a little bit more brittle just by virtue of age. And then when menopause happens, when ovarian function starts to stop functioning, estrogen levels start dropping down, which is happening late 40s into early 50s. There is some direct damage potentially onto our biological systems. That damage doesn't have to be profound, but if we are already coming into that phase of life with burden, health burden, then that can be exacerbated. So we should be aware of these aspects. Now, I am originally from Pakistan. I grew up in Pakistan. I received my training in the UK before I came to US. I received my training in US, and I can share with you through my own personal journey through the lenses of a healthcare provider who practiced in 3 different continents across the globe. I can assure you that the problems of women's health are the same. The burden on women across communities is the same. We talk about high income countries, low income countries. We talk about the advanced Western civilization versus the developing world. But the burden on women in terms of nuanced health aspects is really the same. One other thing that, as I was in preparation for this conversation that I was going to have, I went through your website and really tried to understand. I have not had the privilege of visiting Portugal, but that's on my list now. But as I was glimpsing through the history that is captured on your page, the one thing that struck me was the commonality, how important family and community is. So we all come from parts of the world and communities where multi-generations have existed in the same space, where young girls have been exposed to aging parents and grandparents, and conversations were more fluid across generations. We are now in a part of the world where conversations get siloed. So young women are not even hearing about these aspects of aging till it happens to them. Our healthcare curricula in schools and colleges are not talking about aging. They're focusing on contraception, they're focusing on fertility. So aging related aspects of life are untouched. Women are under care of women's health providers in their reproductive years. They're receiving attention for contraceptive needs, for fertility related needs. But once they go into transition, a chunk of that population really, unless they have a problem, they may not even be seeing healthcare providers. So the opportunities for prevention are missed. And this conversation is really about we all should collectively think about our next phase. We should think about disorders of aging that just by virtue of aging we may be at risk for. We should place those understandings in the context of our personal journey and our genetic predisposition and seek out healthcare interaction with healthcare so we can have these conversations preemptively rather than wait for a disorder to happen. And then all we're doing is putting band-aids to try and mitigate it. We would not be able to prevent it. So I think these are the conversations that I'm hoping to open the conversation on. One thing to underscore is of the burden of health disease of aging. What are those diseases? It's really cardiovascular disease, it's cancers, it's metabolic disease, including type 2 diabetes. It's mental health and cognition. So risk of dementia, which is a more extreme aging related phenomena. All these diseases, if you start connecting the dots, you could connect them back to a few things. And those things include metabolic dysfunction, adiposity, weight gain, poor sleep, stress, lack of opportunities and interventions to address stress preemptively. And social engagement, just as a therapy, just being interactive in the context of aging, social engagement is able to harness so many of these disorders. And social engagement is a group of people coming together, whether they're sharing stories, whether they are joining a Zumba class, whether they are, playing bingo. But the engagement is a huge therapeutic modality. So we as people have become dependent on prescriptions. And we need to recognize that the vitamin that comes from diet and fruits and vegetables works way better than popping the pill of that vitamin. So similarly, recognizing that so many of these therapies are in our hand if only we paused, reflected, looked, and then seeked out. So that's my entire spiel. And why are we even talking about this is because women are spending now almost 50% of their life in a postmenopausal phase of life. Average age of menopause in the Caucasian population is about 50 to 51 years of age, but we are all a part of a bell-shaped distribution of population. So while the midline is 50, there are many who are becoming menopausal between 45 to 49. There are many who are, it's a little bit lesser, but many who are getting menopausal between 51 to 53. Early menopause is when menopausal age is less than 45. And premature menopause is menopausal age is less than 40. Why are these yardsticks even placed? They're placed because the earlier you become menopausal, the more longer you're going to live in that state of low estrogenic environment. And what we have learned across multitudes of studies is the sooner the ovarian function goes away. So premature menopause, ovarian failure happening before age 40 does increase the risk of multiple health problems, including cardiovascular disease, including stroke, including dementia, including Parkinson's, including risk of fragility fractures, including dying from these conditions. So not just risks go up, but mortality goes up as well. Between age 40 to 45 is another vital chunk of time that menopause may be early, but some of these disease processes can get accelerated. And what we have learned in this 40 to 45 age group, what we have learned is women who undergo surgical menopause, which means their biology was not menopausal, but for one reason or the other, they had to have their ovaries removed. That population between 40 to 45, these are ovaries, function is dwindling, but it's still functioning. That translates into risks again for chronic diseases, including risk of fragility fractures, including risk of cardiovascular disease, as well as cognitive dysfunction. So I think we really need to understand timeliness in these chunks of life, become highly relevant in determining the longevity, what's going to happen 10, 15 years from now. So if we could collectively focus on prioritizing well-being and wellness in this window of opportunity, which just stopping of periods is a hallmark. It's a shout out. Hey, body, be attentive. Next phase of life may be a little bit more challenging, but you can do something about it now. Age at menopause, as I mentioned, 50, 51, for the average population, it's primarily genetically determined. So important to have these conversations with our elders in the family, female members in the family. Mom, what time did you experience the perimenopausal phase and what time did you become menopausal? Recognizing 1 to 2% of the population, and which comes to millions of women across the globe, may have become menopausal before age 40. That is prematurely. That tends to be a little bit overrepresented in populations where there's a family history of early menopause or premature menopause. So be attentive to the journey. Menopause age may be a little bit younger in socioeconomically deprived populations. So nutrition is important. Stressors are important. Chronic stress in life harms many parts of our body, including our ovarian function. So distress, chronic distress, so women with a history of abuse, sexually abuse, psychological abuse over lifespan, ovarian failure may happen a little bit earlier than anticipated. Lots of conversations about, are women who start menses early in life, say age 10, 11, are they destined for early menopause? Data are all over the place. So that's not the worry. But women who meet criteria for a diagnosis of polycystic ovary syndrome, which is a common endocrine phenomena in reproductive age women, almost 5 to 7 to in some populations, 15% of women may meet criteria for PCOS, polycystic ovary syndrome. Data seem to suggest that in women with PCOS, menopause may be delayed by a couple of years. Smoking, so some environmental detriment to ovarian biology. Smokers, again, lifetime smoking. And it's not just active smoking, it's passive smoking too, being exposed to tobacco exposure. I may not be a smoker, but I grew up in a family where everybody was smoking, or I worked in an environment or my partner smoked inside the house, and that's where my exposures are happening. Smoking is harmful to ovarian biology. Menopause may be accelerated by almost a couple of years. Meat consumption. in terms of what do we eat? Meat consumption is tied, protein is a very healthy thing, but where is that protein coming from? What kind of meat am I utilizing? So age at menopause may be a little bit later in meat consuming populations, but at the same time, certain risks for cancers become higher in certain, particularly red meat consuming populations. These are all nuanced concepts to think about. Science is, the efforts are focused on extending longevity. We are so much better in treating and preventing early death from disease, but we are not that great thus far in retaining quality of life in those in whom longevity has been extended. A prime example are cancer survivors. So that's a population that is increasingly developing, is the chunk of women who became menopausal because of treatment they received for either chemotherapy or radiation they received for cancer management. And they were cured of their cancer, but at the expense, yes, their ovarian failure happened earlier. So that's a burgeoning population in this era of development. But quality of their life, there are not that many efforts happening in terms of, as we are extending longevity, how are we ensuring that the quality of that life and general health parameters are optimized as this population ages? So lots to think about, but recognize this is a plan. When we start the first job, we think about a retirement fund. We start planning very early on, right? So menopause is that point where you're really going to cash in on your retirement fund. So you've got to be thinking about your retirement, which is cessation of ovarian function way early on. So you can plan. And as a part of this conversation, in case there are men in the audience, this is not just about women. Men are going through reproductive aging as well, except their biology is silent. So they're not having these hallmarks of, hey, be attentive. But when your spouse is going through that, maybe that's your hallmark to say we both should be doing something towards healthy aging. This is a busy schema that I don't expect you to read. I just want you to bring your attention to this horizontal green line, which has divided into chunks. So when a girl enters her pubertal stage of life, and if she's privileged to be living long enough, there was a time women were dying. Well, children are dying even today of infectious diseases in many parts of the world. They're not even making it to adulthood. The children who make it into adulthood, female child, biological female is what I'm talking about, enters puberty. Once she enters puberty, her reproductive machinery becomes active. Estrogen production starts to happen. Lots of good things happen. But just like in any animal biology, our biology is geared towards reproductive competence, so we can contribute to our own species. And then as we live long enough, we take care of that next generation while we are around, and then we are the receding ones and they are the rising ones, right? But now in the human species, we have enough knowledge and understanding to be able to apply the lessons we have learned in our reproductive journey to pass it to our next generation, so that the young girls should be learning from their mothers and their grandmothers and their aunts and uncles and dads and brothers too, about how to optimize the healthy aging. So from first on period into reproductive years, be attentive to menstruation. Regularity of periods is a sign that your biology is functioning normally. Irregularity of periods is a sign there may be something wrong, not just for fertility, which can be fixed, but it may have implications for your long-term health, right? So be attentive to these reproductive years. Endometriosis is a common gynecological condition. 3 to 5% of the population gets diagnosed, primarily because of symptoms of pelvic pain or fertility problems. We are learning more and more. Patients diagnosed with endometriosis are at a lifetime risk of cardiovascular disease. So some processes are changing that are placing them at this long-term risk. So their fertility may be addressed. You could address their pain with the symptoms. They eventually do become menopausal, and menopause is a welcome phase because pain eases off. But their risk profile hasn't changed, so we need to be attentive to that. period of menopause transition is when the period menses start becoming irregular, hot flushes, night sweats start happening. This is the time where quality of life could be affected by these symptoms, but it's also the time where our biology is changing. Women start gaining a little bit more weight. They're doing the same thing they were doing before, but they're gaining a little bit weight. This is also the time where, as a population, so we are at a phase of life where parents are aging, partner is aging, children are getting older. They may be leaving home, bringing new challenges in their spirit. So women are between this bookend of stressors at this point in life. How much of these phenomena are purely transition related? How much of these phenomena are life related? How much of these phenomena are aging related? Because aging is continuing along the background, right? But transition is the time to pause, to say, you know what, my cholesterol profile is shifting. Yes, my weight gain is changing, but part of I need to be attentive. If I'm not sleeping well, my efforts at weight loss will be less effective. If I am not eating healthy, if I'm switching from a physically active lifestyle to a desk job because my work demands it, because I got promoted and I've got much more things that I'm now dealing with than I did before, but I'm juggling all these things which are impacting my metabolism. And if I'm gaining weight around my waistline, that is a hallmark of risk for, this is insulin resistance, risk for diabetes, risk for cardiovascular disease, right? So these are already manifest here. All we have to do is pause, understand what could be factors at play, and understand that the map that worked for me a decade earlier is not going to work now. I need to change my strategies a little bit towards optimizing weight loss through better effort. I could be exercising 5 hours a day. I may not achieve the weight loss goals unless I pay attentive to my sleep, my mental health, and what am I eating, and when am I eating, and how much am I eating. I don't need to go and commit to these extremes of diets. I just need to pause and understand what's happening to me. Because we are like those old watches where every cog is connected to every other cog, and one thing turns and then the other thing turns. So sleep, mental health, critical to all these shifts that happen. From the time the final menstrual period happens, our bone loss gets accelerated. Within the first 5 years of the final menstrual period, we can lose anything from 5 to 20% of our bone mass. So if I'm the woman who comes from a family where a mom, a dad, a grandparent broke their hip in their 60s and 70s, where there was a history of osteoporosis, I need to recognize I have these probably genetic risks. If I was the person who skipped my periods, whether because of stress, whether I had an eating disorder when I was young, right? My skeletal cache may not be as effective. I may not have built my bones as effectively, and now I'm going to lose them. So all the more reason to be attentive to strategies to optimize my bone health. Have conversations with your healthcare provider that, hey, based on my family history, based on my personal history, do you think I could get my bone density tested now rather than wait till age 65, which is where Medicare approves for a bone density scan? Maybe I need it sooner, right? Genitourinary symptoms. So what used to be called vaginal atrophy, vaginal dryness, vaginal discomfort, painful sex. This starts to happen in late 40s when estrogen is still on board because tissue is starting to change. Gets exacerbated after menopause. Once it gets exacerbated, the quickest and the easiest thing is to avoid sex, to withdraw, to have, to say because it hurts and therefore I don't want it. Because I don't want it, I don't want it. So the libido, it becomes a catch-22. So for the partnered women, it's extremely important to understand, and for not even for non-partnered women, to understand how biology, how the links, cogs are connected to each other. So be attentive to strategies that can improve vaginal health, sex does not have to be painful, but it requires to be attentive. Attentive to what is happening to me. Infrequent sex will only make things worse. Why is sex painful? Is it dryness? What can I do about it? I can use lubricants, I can use moisturizers, there are things that are available over the counter. Data seem to suggest that postmenopausally women who continue to have frequent sex have better vaginal health without hormones. A part of that is this concept of if you don't use it, you will lose it. So just the act of intercourse, stretch of the vaginal skin, improves the blood supply to the tissue. So it sustains its own health. But the key here is being attentive to the symptoms. You can bring these conversations forwards to identify, when do I need a prescription? What kind of a prescription? How frequently do I continue? And there are many safe strategies out there. But all these conversations, we can only partake in these conversations if we are aware of these changes that are going to happen, that lie ahead. So we can preempt this. And rather than approaching them as a doom and gloom, if we can harness these even before they happen, they don't have to burden us, right? So let's, in the time of this journey from menarche, first period to into menopause transition, be preemptive of what's coming next. How can I optimize my next? And transition is the time where we can optimize our aging part. Common symptoms, I've already mentioned, hot flushes and night sweats, poor sleep. Poor sleep. If I'm having night sweats, if I don't get a restful sleep, my day will be horrible. My mind will be foggy. My metabolic burden will worsen. I will have less efficiency in weight loss through strategies that were working for me before. My mental health will not be good. My relationships will get affected. It all comes through together. So if you are having sleep interruptions, particularly new onset happenings, I was doing fine in my early 40s. Now something has happened. I may not even be perceive that it's a flash that's waking me up, but something is waking me up. And then the rest of the awake moments, I'm worrying about what happened during the day, right? So there are stressors of the day that we carry through the night. And when I'm awake, my mind takes over. So now this requires more than hormone therapy. It requires acknowledgement. Well, what's worrying me during the daytime that I'm utilizing the awakening to ruminate about? So I need to address my psychological well-being independently of my hot flash or a night sweat that's waking me up. Body aches and pains are common as well, particularly in certain populations, such as South Asian and Southeast Asian women. Body aches and pains are described a little bit more, rapid heart palpitations. Some patients present just with palpitation. I am seeing more and more patients in the perimenopause who are coming, who used to have PMS, premenstrual, just before their period, their mood would become a little bit off. Irritability would set in. But now in transition, they describe raging anger for 2 or 3 days before their period. They feel like they're losing their mind. They don't know what their family knows when they're about to get a period. It used to be subtle when they were younger, but it's becoming exacerbated here. Again, don't think you're going crazy. You're not. But these are hallmarks that you be prepared that if I have PMS at younger stages of life, maybe transition may be a little bit more challenging. Let me have these conversations sooner rather than later. And this is a busy slide with lots of lines. The vertical line defines the time of the final menstrual period, beyond which 12 months later you're told now you're menopausal. Well, hot flushes and night sweats, we used to believe that they only center around the final menstrual period, a couple of years before, a couple of years after. But what we have learned, there are huge differences in the patterns of hot flushes. The classic pattern is hot flushes start increase. This is the red line. They are pretty low. I mean, some premenopausal women get hot flushes, particularly before their periods. That's when the estrogen drops. But usually within 3 to 4 years before the final period is where hot flushes start to increase in frequency. They peak within 1 to 2 years post final period and then gradually ease off. And that gradually ease off can take 5 to 7 years, right? So it can be. So depending on how severe this bother is, you don't have to sit it out. There's lots of opportunities available to address the severity of the symptoms, including hormones and non-hormones. There are some women who continue to flash and they never end. So women who are burdened by severity of hot flushes and night sweats in their premenopausal years, chances are their symptoms will just continue. So this is not where you grind your teeth and say, I'm not going to do anything about it. If it's affecting quality of life, you should bring it up because moderate to severe hot flushes and night sweats, which affect quality of life, not only affect quality of life, they have been tied in with the risk of cardiovascular disease, with risk of stroke, with the risk of fracture, with risk of cognitive decline. So it's not just that the flash is the bother. Well, when I get so bothered, what other systems get disturbed in my body, right? So it becomes you're ringing loud within you. And that ringing can have biological effects, which could be burdensome, right? So be attentive to these. Now, if hot flushes are one here or one there, yes, I may be having hot flushes, but they're not bothering me. If they're not bothering me, let me not make that a pathology and a disease. Let me just understand, you know what? It's a phase of life. It's not affecting me. And I don't need to be taking something for it to get zero flash. So that's where a part of it, this understanding is reproductive aging. Aging is not about zero of anything. I want to harness my risk. I want to improve the quality of my existence till a point when I'm ready to go. And I hope and pray that when I go, it's going to be like this, right? So that's what planning for a healthy aging is. I want to avoid chronic diseases. I want to avoid conditions which will make me dependent to a point where I lose my independence. So how can I keep myself engaged and independent? Because there's only one surety in life, and that is of death, right? So let's not pitch to the population that, hey, hormone therapy is a panacea. It's going to save you from death. Nothing is going to save us from death. We can postpone things, but we want to postpone it while gaining quality of the years gained, right? So so just be aware that hot flushes and night sweats have different patterns. At an average, 5 to 7 years, they can last beyond the final menstrual period. It is how burdensome they are on you, which should dictate what should I talk to my healthcare provider about. So I want to know what are my options for management. This panel on the left is again showing the same. This is U.S. multi-ethnic population residing in the United States. Portuguese population is not represented here. Populations include whites, African heritage, Asian heritage women, and Asians include those of Chinese heritage and Japanese heritage, and then Hispanic population. Well, what we learned from this study of women across nation is there are in this panel on the right, that there is variability in severity of bother. So women of African heritage seem to be the most severely burdened by vasomotor symptoms, hot flushes and night sweats, and they last the longest in that population. Asian women tend to have less of a bother. The one thing, being of South Asian heritage, I bring to this conversation is I am not 100% convinced that we understand. This is all research based on questionnaires filled, right? But we need to understand cultural nuances. Not every culture is comfortable acknowledging I have a problem. Not every woman in every culture is interested in talking about certain aspects of their biology, right? So are they not acknowledging because they are not comfortable with those conversations versus, hey, they're just not experiencing those symptoms? So there's so much that we don't know that we need to approach this in the context of the patient that I'm dealing with. Who is the person? And what is a priority for her? And how can I make her comfortable so she's able to share her burden with me so I can help her achieve what I can help her achieve, right? So flash is therefore not just a flash, a hot flash. It ties into so much more: poor sleep, anxiety, quality of life, all these things that I've already talked to you about. And then also recognize there are certain disease conditions. Now, menopause is not a disease. Aging is not a disease. It's a phase of life. But there are diseases, including certain cancers, leukemia, certain infections, HIV, for example, which can present with night sweats and hot flushes. So we shouldn't just assign because a woman is having these symptoms that I shouldn't think about anything more. This is menopause and nothing else. So we've got to be attentive to the breadth of possibilities for the right patient. And then when there are symptoms, there are lots of opportunities available. There are lots of tools in our toolbox to help you, the patient, you, the person, feel better. Some of them are hormonal regimens, some of them are non-hormonal regimens. They both work well. Hormonal regimens are highly effective regimens, but not every patient is a candidate for a hormonal regimen. So there are certain women, such as women with a history of breast cancer, particularly hormone estrogen receptor positive, progesterone receptor positive breast cancer. Those women where hormonal signaling is thought to be relevant to cancer development and progression, where hormone therapy is not the right treatment of first-line treatment of choice for their hot flushes because they have lots of options of non-hormonal strategies. Another class of women where hormonal therapy may not be the right agent are women who are now 10 years or more beyond the onset of menopause. So aging has happened. That's the population where their plumbing has gone rustier just through the process of aging. That's a population who is more at risk for stroke and heart disease happening. Remember, biology was so geared. So this is the concept of there's a window of opportunity, and that window of opportunity is around the time of the final period. First 5 years after the final period is the safe time for the vast majority of reproductively aging women, where hormone therapy could be very safely considered to treat hot flushes and night sweats in the right patient population, which means no breast cancer, no hormonal cancer risk, no personal history of strokes, no personal history of high blood pressure, right? So lots of vast majority of women within the first 5 years, hormone therapy would be an effective tool to address her symptoms as well as to minimize the skeletal harm that can come within the first few years of menopause. Beyond 10 years, if you have not seen hormone therapy and then giving you back hormones, there may actually be risks of hormone therapy because risks are building on the aging related changes that have happened. And this is what we saw, if you are familiar with the Women's Health Initiative studies that happened, that were conceptualized in 1980s and were instituted in 1990s, where the results became apparent in early 2000, was when we were prescribing hormone therapy to women in their 60s who were at least 10 to 15 years from the time of their onset of menopause. We saw harm. The harm was not humongous. There were 7 extra cases of breast cancer, 6 to 7 to 8 extra cases of heart disease happening per 10,000 users, but they were happening. There was harm coming. And those were not women who were using hormones for hot flushes. Those were women where we were prescribing hormone therapy because we believed then that estrogens were great for heart disease prevention, regardless of age. Well, what we learned was in early stages of reproductive aging, phase of transition, particularly in the premature ovarian failure and early menopausal women, where estrogen alone may have a role. In terms of preventing long-term risks. But with age-appropriate menopause, so much more is way more effective than hormone therapy in preventing cardiovascular risk. So don't be thinking that I should start hormone therapy for my heart benefit. No, you should start hormone therapy if you're having symptoms of that would benefit from hormone therapy. And hey, by the by, not only will my symptoms get better, I will get some adjuvant benefits, such as bone protection. But don't be using hormone therapy for cardiovascular benefit. Role of hormone therapy is for symptom management. Lots of non-hormonal agents are now available, which are very effective for hot flushes and night sweats and sleep issues. These included class of antidepressants, and there's this new class of drugs, which literally is target bombing in the brain, in the area where the hot flush arises. These are called neurokinin receptor antagonists. And there are now 2 drugs that are available on the market, very effective for hot flush and one for added benefit for sleep. So when we are thinking about management, which tool from my toolbox do I prescribe this patient? I'm balancing what are the benefits she will have? What are her risks based on her profile, her journey, where she is now, and her time from the window of opportunity that opened up for her? Where is she? What am I giving this tool? What am I going to use this tool for? What added benefits or added risks will hormone therapy give her? For this patient, what is her bother? Who is the patient? And what am I treating? And what am I trying to prevent, right? So this is what's going on in the healthcare provider's mind when they're talking to the patient. And it is a privilege when you have a patient in front of you who comes to you with these questions. Hey, doctor, these are my problems. This is what my journey has been. This is my family history. Talk to me about, I have read a little bit about this. Why would you prescribe me this and not that? So let's have a conversation so we can glean the most for everybody's benefit, right? Um, so vaginal symptom, just quickly, yes, hormone therapy, and it's vaginal estrogen, which is so benign, which is so safe. And there's vaginal DHEA, which is a pre-hormone approach. These are strategies available for vaginal health, but vaginal estrogen alone will not correct this. You have to think about other things in the vagina. Use that area. Utilize if you are scared of discomfort. So you're going to tighten the pelvis when sex is about to happen. No matter how much estrogen is on board, discomfort will not go away. So let's get you back to that place where sex doesn't have to hurt. Sometimes that's using vaginal dilators with the use of moisturizers, with the use of lubricants to make you feel comfortable that it doesn't have to hurt. So when you're then attempting, you are optimizing the scenario, and ospemifene is another oral agent available for vaginal symptoms. So let's then talk about turning transition into an opportunity. So we are optimizing our then. Why am I even talking about it? At the end of the day, the biggest killers of women are heart disease, certain types of cancers and strokes, and the biggest burden to any healthcare system in an aging population, with dealing with an aging population, is fracture-related burden. Fractures dominate in terms of dollars spent in taking care of the aging population. Obesity creeps up. Transition is the time where things are happening. So there's a metabolic transition happening as menopause transition is happening. Women start to gain more and more percent body fat. So total muscle mass starts to go down and percent body fat starts to go up. And it's the bad fat. It's the fat around our waistline. It's the fat which is called visceral fat. Part of this, stress hormones are playing a role here. Part of it, brain hormones are shifting. Part of it is insulin resistance is happening. Part of it is poor sleep and stressors are feeding into insulin resistance. It's not just last declining estrogen, many other things are at play. So let's be attentive to these. And this weight gain not only has cardiovascular effects, it has brain effects. So obesity itself is a risk factor for cognitive changing starting to happen. So let's approach this final period, the last menstrual period of that transition phase, as a declaration that window of opportunity has started. This is the time that if I can maximize optimizing my health, my future will be taken care of, right? So be attentive to your innate risks, be it genetics, family history, be attentive to your own vulnerabilities, be attentive to the timing, be appreciative and cognizant of what can you do now, such as lifestyle, such as stress reduction, such as timely initiation of interventions, so I can add to my protective strategy and identify what is the resistance in me against the things that can help me. Many of us, if we start being attentive to why am I so rigid, that you identify that some of the blocks lie within us, that we can fix them, right? So why am I even talking about this to you at this forum? So, I was giving a talk to a Pakistani audience actually 2 weeks ago. And I went into this website where I was looking at what is the disease burden in your women, in your community? What are the biggest top 10 killers in the Pakistani community? That's where I was. And when Susie had approached me, I was like, let me look at the Portuguese women. And lo and behold, what are the biggest killers, top 10 killers of women ages 50 to 54, 55 to 59? Sorry, this is just a reminder to me that 50 minutes are over, so I should wrap up. In your population, breast cancer dominates as the biggest killer in this young population. Then comes other cancers, including lung cancer, bronchial cancer, tracheal cancer, colon cancer. There are screenings that are available to prevent these things. Some of these, there may be vaccines available to prevent something. Stroke and ischemic heart disease is low down in your as the killer of women in their 50s into 60. Stomach cancer, again, is a risk factor. And then cervix cancer. So HPV vaccination can eradicate this risk of cervical cancer, right? So these are being attentive to what's happening to women of our community and why. Why is breast cancer such a dominant risk in your population? Really being attentive to that. In 60 to 64-year-olds, again, breast, now recognize one thing, COVID-19 is the second biggest killer of this age group. In the older population, COVID-19 is the biggest killer of, and this is data from 2021 that I'm talking about. Cancers again dominate. Ischemic heart disease is and stroke is the third. Again, a chunk of cancers. 65 to 69 is where stroke and heart disease starts to come up. Now, I can tell you that in the Pakistani population, stroke and ischemic heart disease is the biggest killer of women from 50s onwards. Cancers are way down. And into the 70s, eighth decade of life is where ischemic heart disease dominates. COVID is still the biggest killer. Breast cancer goes down. COVID is still a big killer. Stroke comes up here. But those cancers are recapitulating. So this is where you as a population may want to use this forum towards conversations of what can we do to in that window of opportunity. We can't change our in utero journey. When I was my mom was pregnant with me, I can't change that. I can't change my childhood experiences, but what I can change is what lies ahead of me. The sooner I understand what things I can modify and intervene, the earlier I can embark on that path. So COVID-19, my God, just based on these aspects to my mind, prioritizing vaccination, COVID-19 vaccine really does prevent deaths. There's no doubt, there's no question, there's no ambiguity about it. So maybe exposures people need to be attentive to exposures. People need to be attentive in your community to vaccination. But then comes cancers. Why are cancers so high at a relatively young age of aging? What about screening mammography? What about examinations, colonoscopy, breast cancer? What factors are contributing to the personal risks of breast cancer? How much of its role is genetics? Be attentive to family history. Be attentive to vaccinations. Cardiovascular disease, again, recognize the risks. Diabetes, recognize the risks. But again, to my mind, just the profile of 10 top causes of death in your community. But remember, it's not death we want to prevent. It's the quality of health for the rest of us that we want to prevent as well. And these causes of death are modifiable. So with that really is the conversation about let's approach this phase of aging as a window of opportunity towards optimizing our then. Thank you so much for your attention. I hope I've been able to make some sense for somebody in the audience, and happy to answer any questions. Thanks so much, Susie.
That was wonderful, Dr. Paul. You didn't even need to read the screen. It was very impressive and very insightful for all of us. And I especially like the Portuguese slides that you had there. I think that is very useful for a lot of people on this webinar today. But we do have a few questions that I want to read off. And I think that you touched upon some of the things. You may have answered her questions, but let's see, let me go back. Karen asked the very first questions. What are the differences in symptoms between perimenopause and menopause? You had a slide up where it showed the trajectory.
You know, the term, thanks so much for that question. The term peri means just around. Now, remember, menopause is a Monday morning quarterback diagnosis. You got to be without a period for 1 year to look back to say, menopause has happened. Perimenopause is heading into that area, which is transitioning, and then that for 1 to 2 years around that final period. So perimenopause is nuanced. Menopause means it happened. Perimenopause, it's around, and around could be before, around could be a couple of years after. The important thing is that symptoms usually start well before the end of period happens. And those symptoms, the commonest of the symptoms really are sleep interruptions, poor sleep, hot flushes, night sweats. Some patients experience cold sweats. Some patients experience anxiety episodes. Some patients initially, they have not sort of put two and two together why this is happening. Some patients experience exacerbation in mood, symptoms that center more around, I'm skipping my periods are a little bit irregular. I may skip 1 or 2 months. But when it's about to happen, my emotions go up and down scenario. So it's a slew of symptoms which did not exist before, which are relatively new in onset, which I'm unable to explain, but there is a pattern. Very few things in biology happen cyclically. So when you're getting periods and these symptoms are happening around the period, be attentive. What are those symptoms? And when I skip my periods and this is a new onset of symptoms, be attentive to those symptoms. And when they happen, they may continue into postmenopause. I showed you the slide, 5 to 7 years, hot flushes, night sweats continue. But remember, not every woman may perceive middle of the night awakening, that it is the night sweat or a night flush that woke her up. All she perceives is my sleep got interrupted. She could not understand why it happened. All she said, I used to sleep fine. And now I'm waking around about the same time, 2, 3 a.m. every night. I just can't go back to sleep. Insomnia, difficulty going to sleep is not as much of a perimenopause, menopause bother as is interruptions. I hope I've been able to answer that question.
Karen also has a second question that you touched upon. At any time, when can hormone replacement therapy be given during the menopause journey? She heard that it's not effective if you have been on menopause for at least 10 years. And you touched upon this, the early 5 years versus
So
later.
step one is hormone therapy for what? What is the problem, right? So I cannot tell you how many women, and increasingly I'm seeing women. So FDA took away the black box warning on hormone therapy products, systemic products in November of 2025. That's a conversation in of itself, why they took it off. But the common lay public has perceived that action meaning, oh, hormone therapy is free game for everyone now. Everybody should be coming using hormones now. Well, the conversation has to come back to say, well, hormone therapy was never a very harmful thing. But hormone therapy was never a panacea for every problem in life either. Hormone therapy's effectiveness is for symptom bother. And its risks are the least the closer you are to the final menstrual period when you start the hormones. Because when body has not seen hormones for 10 years, and then a minimum 10 years, and then you add back hormones, even if she was continuing to have hot flushes. She happened to belong to those 20% people who just continued to flash, right? But when her biology has not seen hormones for almost a decade, and now you reintroduce the hormones, there is a potential. Things have changed in her blood vessels, things have changed in her tissue. And at that point, hormone therapy may still benefit her hot flushes, but it may cause harm. Harm risk starts to go up. The older we are, the more we are away from the last menstrual period when we first introduced the hormone therapy. So it's not that the hormones are not effective then, it's just that the added harm risk goes up. And then you have to think about, why am I choosing to give you hormones? Why shouldn't I give you a non-hormone therapy for your bother, right? So two things about hormone therapy is, what should I be considering hormone therapy for? What's my bother? And when is hormone therapy the safest option for me? Which really is in that window of opportunity phase for the common symptoms of menopause. So don't think that hormone therapy will prevent dementia risk. No, it will not. If anything, dementia risk was higher in the WHI when older women were using hormones, right? So don't think, I'll use hormone therapy to protect my heart when I have not paid attention to my mental health, my physical activity, my percent body fat, my sleep, my stress. And I'm choosing to say, hey, let me just take hormones because I want to protect my heart. And I happen to be somebody who doesn't really have hot flushes. Well, don't use that. That's not going to work for your heart.
This next question from Hera touches upon the Women's Health Initiative and the myths behind that, and you touched upon that as well. The wrong age was being given
So Susie,
hormones.
thank you for that. Hira, thank you for this question. This is so important. When WHI was conceptualized, and again, as you know, there's such a learning in being the learner who has gone through phases of life as the patient, right? So I have not only witnessed the field of menopause through the eyes of an investigator and an educator and a healthcare provider through my 30 years of experience in healthcare across 3 continents. I, as an individual woman, have gone through stages of reproductive aging and the perimenopause and the menopause and the burden of symptomatology, right? When WHI was being conceptualized, the study, that was the time where hormone therapy was being prescribed to women, regardless of age, regardless of symptoms, for cardiovascular benefit. That was the time where I was a trainee, when I participated in prescribing hormone therapy to women in the 80s. Hey, ma'am, have you considered hormone therapy? It's good for the heart, because observational studies were showing us cardiovascular benefit. Well, who were the women who were benefiting? They were the younger women. They were the nurses' health study, which showed us this is women who were in healthcare, who had healthier lifestyles, who were aware of health aspects of smoking and other detrimental, right? They were avoiding those things, whose work life was being affected by hot flushes, who chose to go on hormone therapy. And yes, and they were in the window of opportunity, and their cardiovascular health was better. So women's nurses' health study was shaping our understanding of cardiovascular benefits, but we applied it to all comers, regardless of who. So when WHI happened, that's the reason why WHI was designed as a trial to prescribe hormone therapy to aging women for cardiovascular benefit, because cardiovascular benefit needed to be seen in those who were using hormone therapy. If you did that trial in women in their 40s, the trial length would have to be 30 years to even see harm or benefit, right? So WHI was conceptualized. Choose the population that this hormone is being prescribed to for the end results that are happening more in this population. So you could see the benefit, right? And what WHI showed us was when you prescribe hormone therapy to the aging population, 80% of women in WHI did not have hot flushes and night sweats. They were not symptomatic. The whole purpose of WHI was to prove net cardiovascular benefit. That was the primary goal of WHI. And what WHI showed was there was no net cardiovascular benefit for the entire population. If anything, there was harm. More events were happening. But when they then parsed out the data, more harm was seen in women who were 15 and 20 years from their final menstrual period. Within the first 10 years of the final menstrual period, there was no net harm, right? So WHI data were really net benefit, net harm, with primary benefit was heart cardiovascular benefit. WHI did not see benefit. WHI saw net harm. So if you stacked all the benefits, and the benefits were hot flushes, night sweats, which WHI was not looking for. So it was not even a benefit in that population. Skeletal benefit, fracture risk reduction. WHI saw fracture risk reduction. Quality of life improvement. Well, those women really didn't have much quality of life harm for their quality of life to improve, right? So not that much. What were the net harms? Breast cancer risk. We knew breast cancer tied in with hormone therapy exposure, particularly estrogen and progesterone, which is what the hormone therapy regimen is for women who have a uterus, which means they've not had their uterus removed. The only people where estrogen alone would work are the women who don't have a uterus. Otherwise, it's E plus P, estrogen progesterone. So we knew estrogen progesterone, there was more breast cancer, but we so believed that the heart benefit would be so much better than the risk for breast cancer, right? We knew estrogen therapy, clot formation, thrombosis risk happened, but we believed that the net benefit will be so much higher than the net harm. But when you stacked all the benefits and all the harm on a scale, the scale was tipped by the harm being heavier than the benefit, right? So even though fracture risk was lesser in E plus P, significantly lesser, colon cancer risk was significantly less in the E plus P arm of the WHI. We still don't know why. What were the mechanisms? We can't quite have rationalized, but we did see that benefit. We did not see that benefit in the E alone arm of WHI. So we think maybe it's the progestin or maybe it's the population. Women with a uterus are very different from women without a uterus as a population, right? So net benefit versus net harm is what WHI looked for. WHI's tragedy was not WHI, it was how the data were interpreted by the rest of the world. The harm from WHI was not that dramatic. Like I told you, 7 extra cases of clotting plus 10,000 in 10,000 users, women. 7 less fractures in 10,000 users, right? About 8 more breast cancers in 10,000 users. These were not it was not like people were dying in the hormone therapy arm, right? But the data were interpreted for the common person as, oh my God, harm exists with hormone therapy. So the world perceived this message, not by looking attentively, then how big is the harm? Because we were all looking at hormones from the eye of heart benefit. And because there was no heart benefit, everybody honed in on harm and said, oh my God, so much harm. And therefore, the utilization of hormone therapy plummeted down, and many women were deprived of the benefits of hormone therapy. Hormone therapy is a very safe strategy for the right person, for the right reason. It was never the evildoer that WHI was interpreted to show. But the problem was not in the clinical trial was designed wrong in my eye. The clinical design of the trial was exactly what we were doing in clinical practice. It recapitulated the practice of medicine then. And I lived that practice of medicine. I was a prescriber of the then. I was a learner of the then. I was a prescriber when the pendulum swung to the extreme of no hormone therapy. When people like myself and many of my colleagues who understood menopause and hormone therapy kept saying, please don't demonize hormone therapy. What WHI has showed us is even in the best of hands, harm can come from something. Be attentive to the risks of the person. Be attentive to the woman you are planning to prescribe rather than be wedded to the tool to say either this is all good or this is all bad. No, this is good for the right person, for the right reason. And this could be harmful for the right person if used for the wrong reason, right? If I'm choosing to use hormone therapy for dementia risk reduction, I'm setting wrong expectations. I am setting it from the wrong person. And I haven't understood the data myself, right?
Dr. Paul, do you have time for a few more
Yeah,
questions?
I have time. I don't want to take
Okay.
other people's time, but
I do want to let people know that this is being recorded. Um, I believe it will be on the PALCUS website. You do not need to be a member of PALCUS to sign up for their newsletter and to follow them on the website. And I'm not sure exactly where on the website it will be saved, but I will find out unless Gracie wants to put it in the chat where exactly on the website. But I do have a few more questions I just wanted to ask you before we lose you.
sure.
And this is a good segue into this next question because you talked about the right therapy for the right person, right? So as you touched upon before, there's a segment of people who had breast cancer, or people like myself who had very bad reaction after being on hormone therapy for like 5 months. That's a long time.
Wow.
Where the doctors thought I was having a TIA, which is like a precursor to a
God.
stroke,
Oh
right?
my
So
God.
what can you say about those people? Like, what can we do with the night sweats that are keeping us from getting a good night's sleep or the hot flashes during the day?
Thanks for this question, Susie. I'm so sorry for your personal experience. But Susie, there are so many effective agents that are out there. There are so many. And the question again, and you don't have to answer this to me, but step one of your question of if you had that side effect, well, what formulation were you on? What was the route? Was it an oral agent? Because oral things by mouth are way more like estrogen by mouth increases the risk of thrombosis, increases the risk of clotting,
Mhm.
right? So part of
Yes.
it is to be play NCIS or Sherlock Holmes or whatever investigative program that your heart reaches out to. I've become a big follower of NCIS. So every clue matters, right? So step one is if somebody is suffering from hot flushes and night sweats, and has tried a hormonal regimen and could not tolerate it. So, first of all, me as a provider, I want to understand more. What was the problem? What was the regimen? When in that context, did this event happen? What were the corollaries to that event? So that's a separate thing, right? I would want to understand before I close the book of hormone therapy on you, the patient. That would be one thing. But secondly, I would say, hey, such as breast cancer survivors, who are hormone therapy, 80% of breast cancers are hormone receptor positive, and hormone therapy is advised against for that population. Having
Mhm.
said that, I have a few patients who have tried everything else, and they are so miserable in terms of hot flushes and night. Nothing else has worked for them. That based on the conversation, they have chosen to go on hormone therapy to say, I'm cured of my cancer. I'm on a preventative strategy right now. I'm miserable. I've tried everything else. I've had a double mastectomy. There's no tissue left behind. I've had my ovaries removed. That reduces my risk of breast cancer. So all of my theoretical risks have been reduced. And I am okay with choosing to go on a regimen that will give me a quality of life. Because there's no data for me to tell you in that patient population harm will come. All I can tell you is, listen, your cancer had these alerts, which makes me worry about if there is a cancer cell lurking around. Would it respond to these hormones? Well, maybe I could choose a hormonal regimen, which is available in certain European countries and United States, which goes by the name of Duavi. Duavi is a combination of estrogen, it's an oral estrogen, and an anti-estrogen, bisodoxifene. And that anti-estrogen has been shown, a cousin of that anti-estrogen is raloxifene or Ivesta, which has been shown to prevent breast cancer because it works as an anti-estrogen at breast tissue, right? So if that was the regimen that we are honing in on, I'm going to say out of my toolbox, this may be the best strategy for you. Combine an estrogen with an anti-estrogen in the context that every other risk has been addressed for you. And you, the patient, recognizes, I, the prescriber, recognize I've tried everything else. And we are both at that crossroad where your quality of life is being affected, and there is nothing that I can tell you that your risk is so high. All I could tell you was based on this galaxy of piecemeal data, right? So if the patient is comfortable with that conversation, and I have tried everything else, and her risk profile is so huge, I'm okay with choosing the tool, a hormone-based regimen. But even in that regimen, I will choose a particular one which may give her the least harm, right?
Mhm. Makes sense.
So,
Makes sense.
but I would tell you, and there are no head-to-head comparisons, but mathematical modeling of effectiveness seem to suggest that the newer class of agents, the neurokinin receptor antagonists, the magnitude of benefit for hot flush and night sweat with them may be comparable to that is achieved with hormone therapy. So you
Dr.
would be,
Paul, it sounds like I need to come see you then.
you need to come, or you don't have to. You talk to your gynecologist or your PCP. Again, the irony is that these conversations don't have to require somebody to come to see a menopause expert because this knowledge should be at the hand. And there are more and more healthcare providers that are now being attentive to menopause management, right? But
True.
again, Susie,
You,
of course,
you've
it'll be my
given
privilege, but
you've given me a lot more to work
I
with
have.
than my OB. So, but there's two more questions here, and then we'll let everybody go. I mean, I could keep asking you questions, but we don't want to take your time. One is this is from the audience. One is from Hara. Um, should women have lab work, blood work to determine the right amount and type of hormones?
Good question. Many patients come with that question. The place for hormone testing is for me, the provider, the prescriber, to ask, why is this not working for her? In my opinion, I am giving enough hormone, but the patient is not responding to this dose. Let me check the blood level because if her blood level of estrogen has gone into the 50, 60, 70 picogram per ml range and her hot flushes are no better, something else is going on here. So, hormone testing of hormones should be in the context of how will that number change my management? If my patient feels great with the regimen I'm prescribing, how high is her level becomes meaningless. You test the level because the level may either tip her into risk for harm, right? So level of estrogen relates to risk of clotting. Or level of estrogen relates to, am I giving her enough progestin or progesterone to protect her uterus? Because she is needing way more estrogen to control her, right? So timing of assessing blood work has to be in the context of this picture is not making sense. I would tell you I'll use this to launch into another question that maybe somebody would have asked already, which is many patients in their 40s and 50s come with a lab result telling me, Dr. Pal, I need testosterone supplement because my level is so low. Well, I'm like, well, why was this level tested? Well, my doctor was testing, and they were like, let's do a whole panel of testing, right? And this includes women who are reproductive age women, women in their 40s who are having periods, their ovaries are functioning. Remember, in a woman, sources of testosterone are adrenal gland, our ovaries, and our peripheral body tissue, including body fat. Adrenal glands or production of androgens, which is a class of hormones that include testosterone, they start going down in our in our late 30s. So if there's an adrenal gland, DHEA starts going down, right? A couple of hormones. Doesn't mean there's a disease. It's just the way biology is. Little bit shift happens in our adrenal production. Our blood testosterone, these are population studies. Our blood testosterone levels do not drop from our 40s into our 50s into our 60s. Menopause is not a state of low testosterone. Menopause is a state of relative androgen excess because estrogen becomes low. Low testosterone level does not mean it's a problem because assays for testosterone hormone testing are very poor quality assays at the lowest range of levels. Assays were designed for male population, where levels are in the 400s or higher range. Women's levels are more in the 10 to 12 to 30s range, right? So back to the question being asked, so many women get their testosterone level tested and then come and say, I want testosterone supplementation because my libido is low. Well, now I got to begin the investigative approach again to say, well, female biology, hormone is the last thing to translate into libido. Nature did not destine 50% of the population surviving to be in a doom and gloom situation post-menopause, right? We were not, biology didn't destine us to be. So let's talk about what is happening. Well, in female biology, libido is the end result when stars are aligned, when relationship is great, when the body is rested, when mind is rested, when there is good sleep. That's when libido and sex is not painful because everything could be fine, but sex is painful. That's a Pavlovian response. If sex is painful, subconsciously I'm going to avoid it next time. Why would I subject myself to a discomfort situation? Well, I got to pause and reflect. Well, what is going into this libido issue with me, the person?
Mhm.
And I, the physician, have to test, then walk this journey with the patient. So many a time, so libido, if you start looking at studies, libido start going down in the late 30s, early 40s in women. Doesn't mean they have a dysfunction. If 40% of the population has something, is it a problem or is it a norm? Well, it becomes a problem for the handful when the frequency of libido goes down that I'm bothered that my libido is low. Well, let's then talk about why is it low. So if a woman is having hot flushes and night sweats and poor sleep, first priority is for me to prescribe and her to understand, let's fix this aspect. I'm not saying no to testosterone. I just don't see a low role of testosterone right now in this process. I want to make you feel comfortable. I want to have your vaginal health improve to a point. And I want to make sure you understand that relationship, quality of relationship is so relevant. I want you and I both to acknowledge that this is also the age when the male members of the community are experiencing erectile dysfunction, premature ejaculation. There is sexuality issues happening in there as well,
Yeah.
right? So, how much of a female sexual response is responsive to the male's response? And so a part of this is to have these conversations, to recognize. So, the population where there's no ambiguity about possible role of testosterone towards libido enhancement is the population of women who have undergone surgical menopause, whose ovaries have been removed, because postmenopausal ovaries are a source of testosterone, and postmenopausal output of testosterone from the ovaries is no lower in the first 10 years of menopause as it is within the 10 years before menopause. So drop in testosterone doesn't happen like that unless you remove those ovaries. So when you
Right.
have that surgically menopausal woman whose hot flushes are addressed, she's comfortable, she's sleeping well, she's in a good relationship, and really that libido part has not come back for her, is where you say, yes, there is a role of maybe adding a physiological dose. In the United States, there is no prescribed FDA-approved formulation for testosterone. There are very few healthcare providers that are even familiar that the dosing needed for women is 1/10 to 1/20th of the dose that is available for men. So when you start going that route, you need to choose the right. And remember, testosterone, depending on the type of testosterone, gets converted to estrogen by our bodies. So when you choose to go the route of testosterone supplementation using a formulation that can be aromatized, that can be further converted to estrogens, which is the natural versions, many of the transdermal testosterone formulations are. You
Okay. Dr.
recognize that.
Paul, not to cut you off, but we did lose about 5 people, and I do have a survey at the end that I like people
Okay,
to
okay, perfect.
fill
Yeah, yeah,
out.
yeah. Good, good, good. So hormones, back to
Yeah.
long-winded answer to why. I wish they were clipped answers, but they're not.
I
Okay.
know. I know. One person's actually asking for something over the counter, estrogen complete. How do you feel about that product? Are you
I don't
familiar with
feel
it?
anything about that. I don't feel anything about that. There are literally
Okay.
no data. Having said that, just to say there's a 40% placebo effect in menopausal clinical trials. There are patients who take it and feel better. I'm all for trying it if you feel better with it. I'm not nobody to argue. I'd say, hey, but don't put your money in it if it's not working because there are no really real data to be saying it's going to work.
Okay. Okay. People were asking about the recording to me. It's going to be on PALCUS's YouTube channel, and I will try and get a hold of it, and maybe I can share it on my page. Also, when this webinar ends, please just stay on a few minutes. There will be a survey at the end. We definitely would appreciate your feedback and let us know what you thought about today's session and how can we improve upcoming sessions. And if there's a topic that you are interested in, you know, please put
Mhm.
that in the comments section. Dr. Paul, what a wonderful job. I'm so happy that you were our very first presenter to our PALCUS group. You are definitely a pioneer in women's health. I've seen you, I was her nurse for 3 years, and I've seen the bedside manner and just
Oh, Susie,
the wealth of knowledge that you have. So
God
people are in
bless.
good hands with you.
What a privilege this has been, Susie. What a privilege it's been having you to work with in the clinical space. But kudos to you for this forum and power be to you guys because this really is a place where you can make a difference. And loads of luck to everybody. And thank you so much for this opportunity for me. All the
Thank
best.
you. Happy Mother's Day
Great
to
night.
you and to all of
Oh,
our
and to you and to everyone.
yeah,
Absolutely.
audience. And please stay on. We're going to end the session, but the survey will start.
Thanks, Susie. All the best.